guys, how you doing? Fred Gonzalez with Fred's Medical Solutions. Today's video is all about CPR for healthcare providers. It's the CPR card that's needed for doctors, nurses, paramedics, and so forth. We're going to be talking about adult, child, and infant CPR with AED, as well as adult, child, and infant foreign body airway obstruction. So let's get to it. A little bit about myself: a firefighter, paramedic, been doing it for about 30 years, and still love it. So let's get into this really quick. And I do teach this class to the layperson, so some of these slides might be a little redundant, if you will. Okay, so American Heart Association standard CPR is pretty much the gold standard of CPR. Red Cross does teach CPR, but I don't think it's for healthcare providers, and I believe their certification is only good for 1 year, to where American Heart Association CPR is good for 2 years, and it's what's needed, like I said, for healthcare providers. Cardio or CPR, cardiopulmonary resuscitation, cardio pertaining to the heart, pulmonary pertaining to the lungs. Resuscitate literally means bring back. So we're going to bring back the heart and lungs, or the heart, lung, and brains, if you will. First thing I'm going to go over is the Good Samaritan Law. What the Good Samaritan Law states is if you render care to a person in peril that's in imminent danger of losing life or dying, and the family believes that by you rendering care, doing CPR, the person died because of your actions, you cannot be held legally liable. They cannot sue you because you don't have a duty to act. Now, fast forward, tomorrow I'm on shift. I have a duty to act. I'm at the fire station. I do CPR. The family believes that my actions caused the death of the person. I can be held legally liable. I can be sued. Now, 8 o'clock in the morning, I'm off shift. I no longer have a duty to act. I don't have a duty to render medical aid to people. There's a guy in front of me in Publix or the supermarket, clenches his chest, goes down, goes in a cardiac arrest. I do CPR. The family believes that because of my actions, he died, and they cannot sue me personally because I did not have a duty to act. The reason I bring this up is because when we get on scene, all you see now is just people videoing and filming and taking pictures of everybody that need help. And I always ask, why didn't you help? Why is anybody helping? And the number one answer I get is, well, I don't want to get sued. Well, that's impossible. You cannot get sued. The Good Samaritan Law also extends to people having a drug overdose. If you are having a drug overdose to the point where you need medical care to be revived or resuscitated, no matter what you have on you, if you have drugs or drug paraphernalia on you, you cannot be charged with possession of drug or possession of drug paraphernalia. And I just recently found this out with a police officer that I ran a call with. The person we were running a call on had overdosed on opiates. I'm not sure which kind, probably Oxycontins. And we needed to give him Narcan to bring him back. He was in respiratory arrest, and he came back, lo and behold. And I asked the sheriff or the police officer with this. I said, hey, what are you going to do? Are you going to charge him or what? He's like, nope, I can't. He's covered under the Good Samaritan Law. They cannot charge them for possession of drugs and or paraphernalia if they need medical attention to be revived or resuscitated. So have that in mind. So we talked about the Good Samaritan Law. All right, next on the list is, when do we stop CPR? When you're physically unable to continue doing CPR, you're doing CPR for a while. By the way, this is a very tiring thing to do. I don't care who you are, how in shape you are. This is a very, very tiring thing to do. So when do we stop? Obviously, if the patient comes back to life or you see signs of life, the patient starts grimacing, purposely moving. Remember, dead people don't move or do facial expressions. That's a good sign to stop CPR. If you're physically unable to continue, you're just fatigued to the nines, you just absolutely positively cannot do CPR anymore, that's when you would stop CPR. Thirdly, if you're relieved by medical personnel of equal or higher level of training, that they get on scene and go, hey, I'm a paramedic, I'm an EMT, whatever, let me take over CPR. Good. Don't be surprised, however, if the paramedics, EMTs get on scene and you're doing CPR. I know I do this all the time. I see the person doing CPR and it's obvious that they've done it before. They're in the medical field and they've done CPR before. I asked them, hey, do you mind continuing doing CPR? You're doing a really good job. The reason for that is I have to now stick tubes down this patient's throat, start IVs, drill a hole in their bone, and draw out medications, get my cardiac monitor ready. I have a lot of things to do. So if that frees myself or another person on my team to not do compressions, it'll go a lot quicker to render the life-saving steps that this person needs. And then lastly, when do we stop CPR? When the AED tells us, right? Automated external defibrillator. There's a prompt on there, and we'll go over that. Contrary to popular belief, the heart does not look like this, right? Does not look like that. I know everybody is disappointed right now, but it actually looks like this. It has 4 chambers, 2 atriums on the bottom, 2 ventricles at the, 2 atriums at the top, 2 ventricles at the bottom. And without getting too technical, electricity flows in the heart. It has its own electrical impulse. It's called automaticity, right? The ability to generate its own electrical impulse. And the first electrical impulse that starts is up at the top right atrium, and it's the patient's right. That's why I'm pointing over here. If you look at my mouse icon, it starts there, then comes down to the AV node, atrioventricular node, then down to the bundle of his, and then makes the ventricles contract, right? It's a wave of pumping. Imagine if there's a calm body of water and you throw a rock in that calm body of water. What happens? You get ripples in one direction. Oops, excuse me for that. You get ripples, you get waves in one direction, right? Imagine the heart electrical system. It beats and then it sends that signal down the heart to pump. The heart doesn't contract all at once. It starts at the top and then goes to the bottom. Now, imagine that same body of water, nice and calm. I throw a handful of rocks in that water. What happens? Now you get ripples in every direction, right? A chaotic, unorganized, non-pulse producing rhythm. And that's because at some point in time, this person's heart, coronary arteries are clogged due to decades of eating pizza, cheeseburgers, drinking beer, smoking, drinking, what have you. Now those arteries become clogged and they lack the amount of oxygenated blood going to the heart like it needs to. The heart becomes irritable. And now instead of having an electrical signal start up on top, now one comes from here, then another one comes from there. All of a sudden, there's electrical signals firing everywhere, and you have a chaotic, non-pulse producing rhythm. And if I were to open these patients' chest and look at the heart would literally be quivering in their chest, right? And that's called ventricular fibrillation, a chaotic, non-organized, non-pulse producing rhythm. And what needs to happen here, number one, is CPR, but number two, we need to apply electricity. Think of the heart as resetting the light switch, right? I want to turn on and off the light switch. Well, think of the AED as delivering electricity and restarting that electrical impulse. That is a viable rhythm. For some reason, Hollywood loves to shock a flat line, right? And we'll get to that in a second. So when I do shock this rhythm, I want it to go back to something that looks like this, a nice organized rhythm, regular with producing a pulse. And I'll tell you what these waves represent. If you don't know, the small waves represent the atriums contracting, and the bigger waves represent the ventricles contracting. And the larger waves represent the ventricles contracting. It's a larger part of the heart, so it produces a larger wave. And this other wave right here that I'm circling, that is called a T wave. That is when the heart begins to come back to its normal relaxed mode. It's called the period of relative relative refractory period. What's noteworthy about that is if you've ever seen people take a blow to the chest at a baseball game, soccer game, football, hockey, whatever, and they collapse, that is because that hit to the chest generated an electrical impulse that made the heart contract when it was about to come back to a relaxed state, and now contracted and caused ventricular fibrillation. It caused that rhythm right there, right? And that is called an R on T phenomenon. Who cares? Just know that if you're at a sporting event and you see someone take a blow to the chest and they collapse, that's what happened. They're in ventricular fibrillation. So flatline, right? Asystole. This is a dead heart for some reason. Hollywood loves to shock this, right? It's no different than me shocking one of these mannequins. They're not going to come back to life. This is a dead heart with no electrical impulses. And what this heart needs is drugs and CPR. Drugs and CPR. I personally have never brought back a person that was in asystole. It's not that it cannot happen. It's just I personally haven't done it. I'm doing it for 30 years. What we're doing when we're doing CPR is we're literally squeezing the heart. We're squeezing the blood out of the heart, allowing for recoil and allowing blood back to come back into the heart. Your hands are in the cartilaginous part of the chest, the sternum that's made of cartilage, and oftentimes what happens is you're going to feel the ribs detach from the sternum. Everyone says the ribs break. It's not a breaking, but it's a detachment from the sternum, much like Lego sets detach from one another. That's what's happening there. The good thing about that is once all those ribs become detached from the sternum, CPR becomes a lot easier because now that sternum is floating and it's a lot easier. I still don't like the feel and sound of that. I oftentimes get the young guys to start doing compressions, CPR, and I can see the look on their face, and I'm like, "Oh, you broke bones." Like, you broke the bones? They're like, "Yeah." I'm like, "All right, I'll take over now," right? But there's an adage in the medical field that it says if you're not breaking bones, you're not doing it right. Especially older patients, older females that have gone through menopause and now have osteoporosis, you're for sure going to break their ribs. But let's be honest, that's the least of their worries, right? So you're squeezing the heart against the back of the spinal column and letting it come back up. American Heart Association is harping now on allowing for good recoil, and they're calling it palms up CPR. So first update from 2020 CPR is, let me show you something here. When you do CPR, right, you interlace your fingers and you come mid nipple line right there. And it used to be 2 fingers below the xiphoid process, put your hand and then start compressions. But they've done studies and they realize that when people go midbrain, they forget all of that and they start pumping on weird areas. So imagine this mannequin, if you will, next time you have a patient or if you find someone that you have to do CPR on. All right, sorry about that, guys. Now, the old way, and still the way to do CPR is you interlace your fingers, start doing compressions, make sure your elbows are straight, and you come straight down. They found out that the elderly population had a problem with that because of arthritis. So the new change to CPR through AHA, American Heart Association, is you could actually grab your wrist and put one hand on the center of the chest and do compressions. If you look at my arm, my elbow is totally locked. It's actually a lot better. For twofold, right? One, your form is a lot better. You're not using the back of your arm to do compressions. Number two, if my hand gets tired, I can switch to the other one. To where the old method, if I was lifting up my hands and I wanted to change hands, it would still be the same thing. So one of the changes, right? Grab the wrist to do CPR, but also they want a palms up compressions. If you can see it on the side, right, when I do compressions, they want almost that palm to come up to allow for good recoil, to make sure that the heart is being completely filled with blood when you do that compression. And we're going to do compressions 100 to 120 beats per minute. And we're going to give 30 compressions to 2 ventilations for 1 or 2 rescue or CPR. All right, so compression rate is 100 to 120 beats per minute, and we're going to give 30 compressions to 2 ventilations, 1/3 the depth of the chest or 2 inches. If you've never done CPR before, if you think you're going deep enough, go deeper. That's the best advice I have for you. You're going to do 4 cycles. One cycle of CPR consists of 30 compressions to 2 ventilations, right? That's 1 cycle, 8 to 930, blow, that's 2 cycles, 28 to 930, blow, that's 3 cycles, 28 to 930, blow, that's 4 cycles. That comes out to 2 minutes of CPR. After your initial 2 minutes of CPR, you're going to check for a pulse. Hopefully your AED will be on, and if there's a pulse, you're going to stop CPR. Allow the AED to do its thing and let you know if it has a shockable rhythm or not. If there's no shockable rhythm, continue CPR. The other thing that AHA came out with is compressions only CPR. I told you you could do 30 compressions to 2 ventilations, but if you don't have a device to put on the patient's mouth, between your mouth, don't put your mouth on a stranger's mouth, because there's a lot of communicable diseases out there that just didn't exist 10, 20 years ago, right? Especially now, COVID and all that other stuff. So instead of doing 30 to 2, we're going to do continuous compressions for 2 minutes and then check a pulse, or let the AED go through its paces and let you know if it's a shockable rhythm or not. And how fast is 100 to 120 beats per minute? Well, if it's this song here, right? Another One Bites the Dust by Queen. Every time you hear that beat, you're going to compress the chest. You're going to do compressions. It's pretty ironic, right? Another One Bites the Dust. Don't sing it out loud, because the family members or spectators are going to be pretty taken back by that. So it serves twofold. One, it lets you keep a cadence in your head of how fast CPR is supposed to go. And number two, it lets you forget about the fact that you're pumping on a dead person's chest, right? So how do we do CPR from the beginning, right? Shake and shout, no signs of life. Look for signs of life. I'm sure you guys are intelligent enough to know whether a person is dead or alive. They're going to be turning purple in color. Their faces are going to be turning blue. We open the airway doing the head tilt chin lift. And how that works is one hand on the forehead, two fingers under the chin, and we're going to lift the head. What we're going to do is look, listen, and feel. We're going to look for chest rise and fall. We're going to feel for breath on our cheek and listen for any circulating air. At the same time we're doing that, right, you can hold the airway open just by putting the hand on the forehead and holding it there. With these two fingers, you're going to find the trachea and go down to the side and feel for a pulse. So at the same time that you're listening, looking, and feeling for breaths, you're going to feel for a carotid pulse. And you do this for no longer than 10 seconds. No longer than 10 seconds. If there's no pulse, no breathing, continue CPR at the mid-nipple line. If there's somebody around you, hey, call 911, go find an AED and come back. Make sure you tell these people to come back. Studies have shown that if you don't give specific directions, when people are stressed, they go midbrain, they forget everything. So call 911, get an AED and come back. All right, call 911. I called 911. They went and got the AED. Now okay, I got to bring it back. Now they bring it back. What else? Okay, so compressions 30 to 2 and cycles 4 cycles, which equals 2 minutes. Another change that AHA came out with is if you have a person that is doing compressions with you, every 2 minutes change out compressors. What that means is I do my 2 minutes, or excuse me, my 2 minutes, 4 cycles. Now my next 2 minutes is coming up, but I feel great. I have an adrenaline dump. I think I could do it. Now I start my second round of 2 minutes, 4 cycles. But I noticed that about a half a minute in, my cadence, my depth, and my recoil are all lacking. And that's because you're starting to get fatigued. So American Heart Association now says that every 2 minutes, switch compressors, even if you feel fantastic, because you feel great now, but halfway through your second cycle, you're going to start messing everything up. And we want to maintain good interthoracic pressure. Interthoracic pressure is the amount of pressure needed to circulate oxygenated blood to the heart, lung, and brains. On a good day, you're doing perfect CPR, your elbows are locked, your chest is above the patient's chest, you're going 2 inches down, and you're doing CPR perfectly well. In our human body, we have anywhere from 5 to 6 liters of blood. And on a good day, like I said, when you're doing CPR, you're only circulating about 35% of the total blood volume of a person. So if you're a little off, your cadence is wrong, your depth is wrong, your speed is wrong, you're circulating less than 35% of their total blood volume. So that's why it's so important to have your form as good as it can be, right? So compressions, and American Heart Association now says minimize the stopping of chest compressions as your number one priority. The head tilt chin lift, like I mentioned before, what happens when you become unconscious is you lose all muscle tone up to and including bladder and bowel contents. So don't be surprised if these people, on top of being purple, they also have urinated and defecated on themselves. A lot of times they puke and throw up. If they start to vomit, make sure you put them on their side, but don't stick your hand in their mouth because that's pretty gross and something bad could happen as well. If they're in puke, blood, and all that stuff, drag them off of it. Don't kneel next to it. There's no need to. I see a lot of people that stay where the nasty stuff is for no reason at all. Move the patient to a cleaner area. Now begin your compressions and ventilations, or your compressions only. So the proper form for CPR, as you see in the picture, your elbows are locked, our arms are straight, your chest is over the patient's chest, and you come down in a nice, rhythmic, even pace at 100 to 120 beats per minute, squeezing the chest all the way down. The second you bend your arms to try and do compressions, all that power goes to your back of your arms, your triceps, and you will not last more than 1 minute. I promise you, because now it becomes some sort of a tricep exercise instead of a compression CPR thing, and you won't last at all. I've seen some guys that were very, very good shape and their form starts to go and they immediately get gassed. This is difficult enough on a regular person. You get an obese or overweight person, it's going to be even more difficult to do proper CPR because there's more mass to compress. If you're doing CPR with another rescuer, you go in a head-to-head configuration. You don't do it next to each other because it becomes very awkward to change. So one person's doing compressions here, the other person is giving ventilations here. If they have a device, after the 2 minutes are over, it's time to switch. All they do is just move up here and the other person moves down here, and now they switch roles and they keep doing that until medical personnel arrive. Automated external defibrillators, you're going to find these anywhere there's a large congregation of people. Supermarkets, sporting arenas, baseball stadiums, gyms. A lot of these places have AEDs, automated external defibrillators. And if you saw that slide that I had just showed, it's in a cabinet, usually going to be where there's a fire alarm pull station or at the exit. And that's usually where you're going to find them. It has a sign up top that says AED. When you do open that cabinet to access the AED, there's going to be a very loud, annoying alarm that goes off. A lot of people think that that alarm advises dispatch that the AED has been accessed, when in actuality, it just lets everybody know in the area that somebody accessed the AED, but 911 is not called. You still have to call 911. This is a training AED, obviously, but you can buy these now at Costco, and single-handedly, these things work phenomenal. I've personally gone on about 8 or 10 calls through the last couple of years that somebody has used an AED on a person and they were in fact in cardiac arrest. And before we left, by the time we get these people to the hospital, these patients were actually groaning. Some of them even talking back to you, asking what had happened. So these things absolutely, positively are worth their weight in gold. And like I said, you can even buy them at Costco now. And all the pads come with visual aids. I'm a dumb fireman, so I need lots of pictures, right? And if you can see how this goes, one picture right here goes at the top right, and the other one goes at the top left, and that mimics the path of electricity, how it flows through the heart. So it always goes in this configuration, just like this, right? Now, if you expose the patient's chest and you see a medical patch somewhere around here, don't put the electrical pad directly over that medical patch. Put it off to the side, but still in this general direction or general area right around here. Also, if you see a device that's underneath the skin that's maybe rectangular or square and you touch it, it's very hard, that's going to be a pacemaker. Pacemakers are typically always, but not always, on the left upper chest, but for some reason this person, they can't have it there, so the cardiologist decided to put it on the right upper chest. Don't put that patch directly over that pacemaker. It's going to cause a lot of damage. And if you see how you're doing CPR, right, my hand placement is just like this. There's plenty of room while I'm doing CPR to put these pads where they need to go. So if somebody comes to get you the AED and they say, hey, you're doing compressions, and they say, hey, can you stop doing CPR while I put these pads on? Nope, absolutely not. Put the pads on around me. I'm not going to stop. And we don't stop doing compressions until the AED tells us. Let me talk about some of the things that comes in an AED kit. They're much bigger, but some things that might come in here are gloves. If there's gloves in there, put them on, because these patients are going to be very, very sweaty. Like I said, they might have puke on them and other bodily fluids. Plus, you don't want to touch anyone's bare skin that might have something going on. So put the gloves on. Something else that might be in that kit is a mask or a pocket mask that fits over the patient's mouth. So now there's a barrier that you can deliver breaths through that device, and you're not touching the patient's mouth. What I can equate to giving breaths to a person to is, you know, those balloons that you make animals out of, like snakes or worms or whatever. Just kidding. You have to blow that hard to inflate the chest or the chest wall, because you have to expand the lungs. You have to make the ribs come up and all the muscle and adipose tissue that's above that, the fat, and you have to blow very, very forcefully to make those lungs expand all the way that they need to. If this is a larger person, an obese or overweight person, it's going to be even harder. You have to blow even more forcefully. And on the opposite spectrum in that, if it's a little old lady, don't blow as forcefully because you're going to pop her lungs. And little infants as well, you're going to give small breaths. Sometimes there's a little towel in there to dry the patients off. If they were drowning victims, obviously you want to dry the area where the pads are supposed to go because they don't stick very well if it's wet. And it has a razor in there. Some of these older guys that they take their shirts off and they still look like they're wearing a sweater vest with all that hair. If these pads don't make good skin to pad contact and they're kind of floating above the skin on the hair and you hit the defibrillate button, I've actually seen these things arc. So there's a brilliant piece of light and you now burn the patient. There's a horrible smell and then they have the outline of the patch. So make sure if you can shave these people where those pads are supposed to go. If you have 2 sets of pads, put the first set on, put them on real nice and tight, real good contact, rip them off, and that'll take the hair off. Now use the second set to put these pads where they're supposed to go. Now that'll make a little bit better contact with the skin. And there you go. I'm a dumb fireman, so I need lots of illustrations. I need lots of pictures, and it's always going to go in this configuration here, right upper chest and left low bottom chest, and it mimics the flow of electricity when you defibrillate them. Like I said, look out for medication patches. Don't put the pads directly over patches. Dry the skin if possible. Shave the chest, right? Make sure that you have good skin to pad contact. And above all else, never, in red, interrupt compressions to put the AED pads on. Never, never, never. We want to keep doing compressions until the machine tells you to, right? So how this works is, in a test question, no test, the first thing you do when you get an AED is turn the unit on.
Apply pads to patient's bare chest. Plug
Right.
in pad connector next to
All right,
flashing
so
light.
I'm gonna go ahead and put the pads on, and I'm gonna take these sticky things off. They're very, very sticky. I'm gonna put them on the chest, right? And it keeps telling you that until you plug this thing in. So there's a yellow light and have a yellow plug and make it very user friendly. I'm gonna plug this in.
Analyzing heart rhythm.
So now it's analyzing the heart rhythm. You're still doing compressions.
Touch the patient.
Now it tells you don't touch the patient at all. Don't even put your knee next to them because it can't interpret your electrical signals as the patient, and it'll say no shock advised. So it recognized it as a shockable rhythm. Make sure you or anyone else isn't touching the patient. Theoretically, if you're touching the patient and you deliver that shock can be translated over to you, theoretically. I don't want to find out, right? So better to be safe than sorry. When you shock the patient, press and hold the button
Shock delivered.
and then release, right? Don't just touch it real quick. So now there's a metronome on that, and that's a little bit older one. And what that metronome does is lets you know what cadence to do that CPR, right? Now, if I don't have a mask to put on the patient's mouth, I'm going to continue doing compressions for 2 minutes. And this AED will tell you when 2 minutes is up. If I do have a barrier device to put on the patient's mask, 28, 29, 30, head tilt, chin lift, I'm going to hold the mask on there and blow on the patient's mask twice and then come back to it. The national average from the time you call 911 till the time they arrive is anywhere from 4 to 6 minutes, depending on where you live. I actually live very close to fire station. Their response time is very, very, very much faster than that. So you could possibly do 3 to 4 cycles of CPR before anyone comes. By the time they get here, you're going to be a tired pup, right? And I've been talking since this thing started to give you an idea how fast or how long 2 minutes is. And I'm going to let this go through its work paces and shock it one more time because there's a prompt on here that's different that they don't tell you during the first time. 2 minutes is a long time. It's still going, right? You're going to be doing compressions. People are going crazy. Make sure that your rhythm, cadence, depth, speed doesn't change, right? Another one bites the dust. Another one bites the dust. Remember that song in your head. Just don't sing it out loud, like I said, because people are going to think you're crazy. So it's still going, and I'm going to let this go to the very end of 2 minutes. And the reason this is so loud as well as the voice prompt is when we get into stressful situations and we get an adrenaline dump, our two things that go right away is our fine tactile senses, right? We're not able to do fine finger movements, and our auditory senses are the first things that go. So that's 2 minutes, right? We're still doing CPR.
Do not touch the patient.
Now I stop doing CPR. I don't touch the patient at all.
Shock advised.
So it says, it's telling you that it has a shockable rhythm still, right? Ventricular fibrillation, that chaotic, non-organized rhythm. So I'm not touching the patient. I'm clear, you're clear, we're all clear. Press and hold the shock button.
Analyzing heart rhythm. Do not touch the patient. Shock advised.
Here we go again.
Charging.
And I hit the reset button on the side. That's why that happened.
Deliver shock
All right,
now.
so press and hold.
Shock delivered.
This is a prompt that's different.
Begin CPR.
Oh, I didn't do it. The prompt that it says, and after the second shock is, if needed, continue CPR. The reason why it says that is oftentimes after the second or even the third shock, you start to see signs of life. The patient comes back. Like I said, I've gone on several calls over my years where the AED was applied to a person, a nurse, a retired nurse was using it. And, you know, obviously, yes, I'm going to believe that that patient was in cardiac arrest because she's done a lot of CPR in her career, and delivered 2-3 shocks, and the patient comes back. They are worth their weight in gold, absolutely worth every penny. All right, so compressions per minute. We're gonna do how many a minute? 100 to 120 compressions per minute at a rate of 30 compressions to 2 ventilations. If there's nothing to put on the patient's mouth, it's just continuous compressions for 2 minutes, 4 cycles. 1 rescuer CPR versus 2 rescuer CPR, it's still going to be 30 compressions to 2 minutes, but every 2 minutes, switch compressors, right? In a head-to-head configuration. How many ventilations or compressions do you do? We do 4 cycles, which equals 2 minutes. And real important here, do you stop doing compressions to put the AED pads on? And the answer is no, absolutely not. Person gets there with the AED and says, hey, I got the AED, please stop. Let me put these pads on. Nope, absolutely not. Work around me, right? I don't care. When can you stop CPR? Remember those 4 things. Patient comes back to life. You're relieved by somebody of equal or higher training. The AED tells you to, and you're physically just unable to do CPR. This is when we would do practice time, but since you're not here, you're watching it. Hopefully you've done it before. I'll show a video here shortly that will show you how it goes in real life. So this is a video here, police officer with body cam, and then the EMS ends up getting there. They deliver a shock, but I want you to see what the shock really looks like. It's not as dramatic as you would Hollywood makes it out to be, where they, you know, arch up and make this big over dramatized movement. It's just a shock, right? They just move.
Our first story takes us to Florida, where officers with the Jacksonville County Sheriff's Office were rushing to the scene of a man found unresponsive in his backyard pool. This entire event was captured on 2 of the responding officers' body cameras.
So they're saying he probably got hit by lightning. They don't know. And if you look at the patient, it's got to be blurred out. But if you look at the face, look how purple that is, right? You can see he's purple. And the reason for that is there's no circulating blood. There's no circulating blood. And that officer, if you see his hand placement, is actually pretty low, right? It's supposed to be much higher than that. Tells him to go get the AED, because ultimately the AED is the most important thing. They rolled him on the side because he started vomiting, like I said, and that's not good, right? If you don't turn him on the side, that vomit will go down their lungs, and they could die from that. It's not good.
Nearly 5 minutes by the time EMS arrives.
There you go. They rolled him again, and he's on his side because they're trying to get all that puke out of his airway.
Even though EMS is on scene,
now they roll him back, and they're going to put an AED on him. You see EMS there getting everything together. They're doing CPR. And that thing they have in their hand right there, that blue thing, it's called a bag valve mask, and that's how they deliver oxygen to the patient without putting their mouth on the patient's mouth. So
Everyone
hands
steps
up,
back for the
everyone
defibrillator to
clear,
deliver
I'm
its
clear, you're
initial
clear,
shock.
we're all clear. Look at the patient down the bottom. When they shock, you'll see him highlighted in white. Boom, there you go. That's it.
CPR for 2
That's
minutes.
that's the
Humans are-
extent of what's going to happen when you deliver a shock to the
The shock.
patient. And then all of a sudden they say, yeah, they got a pulse back, they got him going. If you could see his face, it's not as purple as it used to be because now he has circulating blood, right? These guys are all high-fiving each other because it's a wonderful, fantastic feeling when you get someone back.
Our first story takes.
All right. Now, let's move on to child CPR. A child, for all intent and purpose, according to the American Heart Association, is someone from age 1 to 8 years of age. And the thing that's going to be different with them is 1 rescuer CPR versus 2 rescuer CPR. 2 rescuer CPR is going to be 15 compressions to 2 ventilations. If I'm by myself, it's going to be 30 compressions to 2 ventilations. But if there's somebody else with me, right, smaller person, smaller heart, I want to circulate that blood a lot faster. That's what's going to happen. Another change that American Heart Association brought up is when we're doing CPR on a child, when we're doing CPR on a child, I don't want to use both hands because they're very small children. Imagine a 5-year-old, they're going to be very small. You're going to break a lot of stuff. So we're going to use one hand and then one hand on the forehead, and we're going to go down and do compressions at a rate of 100 to 120 beats per minute. 28, 29, 30, pinch the nose and blow, or don't blow, just continue doing compressions. One of the other changes that came out through American Heart Association in 2021 is we realize that there's a lot of obese and overweight children out there, and there's some big 8-year-olds. So now American Heart Association gives you the liberty to figure out if you need to use 1 or 2 hands when doing CPR on a child, right? That's another change that came out. Use your discretion. You'll know when you need to use 2 hands and when you need to use 1 hand. For AED pads, the problem with putting these pads on a child is when I have a child or an infant, how much electricity I give them depends on how much they weigh. These devices are maxed out at 360 joules, and that's not how much electricity I should give them. If I have a child or an infant that's in CPR, that needs CPR, it's because usually, I'm not going to say always, but usually it's because they have an obstructed airway, they swallowed water, they were drowned, or something happened. Their hearts are perfectly healthy. They haven't been eating cheeseburgers, drinking beer, and smoking cigarettes for the last 30 years. Their hearts are nice and strong and viable. The heart's not the problem. So shocking them may or may not be the best option when you have an AED. Now, there are other pediatric pads you can use for a child, but if you can deliver good, strong breaths to these children, they're going to be very resilient and they're going to come back a lot better than some adults are. So the big difference on children that I want you to take away from this is if there's 2 rescuers, your compression to ventilation rate now goes from 15 to 2. And if you're by yourself, it's 30 to 2. That's the big change. And you have the liberty to use either 1 or 2 hands for doing CPR, depending on how large the child is. Everything else is the same on child CPR. There's a picture right there showing you how it should go. And that kid's probably around maybe 6 or 7, I guess, normal sized child where you would just use 1 hand. But imagine a larger child now, you'd have to use 2 hands. All right, now moving along to infant CPR. Now, I can't use an entire hand on an infant because of the fact of how small they are, right? If I use my entire hand, I'm going to cover their entire chest and abdominal cavity. I'm going to squeeze all kinds of stuff that doesn't need to be squeezed and cause more harm than good. So you guys can hear that lightning outside. So with children, if you got to always remember your middle finger is always mid nipple line and then 1 finger is above that, right? So I want to do compressions and I come straight down at a rate of 100 to 120 beats per minute. and I'm going to do 30 compressions to 2 ventilations. If I decide to do ventilations on the child, make sure you cover the nose and mouth, not just the mouth, because air follows a path of least resistance. And if I blow in their mouth and don't cover their nose, it's going to come out their nose and not in their lungs where it needs to. Don't be as forceful blowing on them as you would with an adult or a child, because you're going to blow their lungs up. Be very, very cognizant of that. So why I'm telling you it's middle finger, mid nipple line. Yeah, it's good right here, right when I'm doing it on the table. But now I hear the ambulance, and I'm not going to wait for them to get all their gear, figure out what door to come in. If you're somewhere else, apartment 17B, they don't know where 17B is, right? I'm going to grab the child. It's storming pretty hard out there. I'm going to grab the child, put their legs between my forearm. Now, your orientation is different. Now, middle finger, mid nipple line. Now my ring finger is above my middle finger, right? The thing with this is I can give ventilations at the same time I'm doing compressions, 28 to a 930, and blow for the baby. When I first done this, I was taught, carry the baby out here, but then I had a real unconscious baby that I was doing CPR on, and this was a true balancing act. It felt like the baby was going to slip out of my hands. So when you do carry an unconscious baby like this, make sure you hold them nice and close. I know it sounds stupid, but some people don't know that. And you deliver your 30 compressions to 2 ventilations. If someone's helping you, if you use 2 rescue or CPR, right, it's 15 compressions to 2 ventilations. 15 to 2, 15 to 2 if someone's helping you. Let me get on here. Another method for doing CPR on a child that I'm not too crazy about, it's called the encircling method, where you put your your hands around the child's rib cage and you press in the center of the chest on the ribs. The problem with that is if you're walking around and you're doing compressions, look at the baby's head, right? What's happening? It's going all over the place, and it could cause damage. Skilwara, you guys ever heard of that? Spinal cord injury without radiographical appearance, right? Big fancy word. It means that they can have an injury to their spinal cord, but the bones are still intact. So I'm not too crazy about the encircling method. It does exist, but I don't really like to teach it. I like to teach the 2-finger method. I've done this myself, and it works fantastic. Now, obviously, when it comes time to using the AED pads, I can't use these pads because it covers the entire chest and abdominal area, right? It's not conducive to delivering electricity. So when you have an AED that is good for children, you're going to have much smaller pads, right? And the thing that pops out of you right away is the connectors are different colors. And that is because when you get the AED and now you plug in the child pads, the machine knows, oh, this is a child, let me decrease the energy levels, right? And these are called attenuated pads, right? That just means that they're designed for infants or children. And instead of going top right, bottom left, we're going to do an anterior posterior approach. And dumb firemen, I need pictures, right? The picture on my left, your right is going to be the child, the pad that goes in the front. And then this pad here, it shows the back of the head, and it's going to go in the back, anterior posterior approach, right? One in the front, one in the back. And we're going to deliver electricity like that. We're going to check for a pulse every 2 minutes and let the AED do its work. Where you're going to find pads like this, attenuated pads, is like pediatrician's office, daycares for children, places where children are usually congregating, Disneyland, stuff like that. This is where you're going to find those pads. But again, the reason this infant is in cardiac arrest is not because they've been eating cheeseburgers and pizza and have clogged coronary arteries, but because they swallowed something or went swimming and now they drowned, and you need to clear their lungs. They are very resilient. They do very, very good if you just don't give up. And I'll show you a video here in a second on why you should not give up doing compressions and ventilations on a child, even if it's completely wrong, right? As long as you do something. Let me get back to the slideshow here. Cover the nose and mouth. We pretty much went over all of that. Don't use adult AEDs on the kids because it's way too big. How do we figure out responsiveness in infants? Well, we can't shake and shout, tap the baby. Hey, baby, what's wrong? Wake up. What's going on? We don't know that, right? So children or infants, I should say, have very, very soft, tender feet. And if I flick the bottom of the foot as forcefully as I can, you're not going to break anything here. This will let you know the level of unconsciousness that the baby is at, any neurological responses that they might have, if their brain's intact or not. If you tap the soles of the feet as hard as you can and you get some kind of a grimace or whimper or move, you know that the baby's still with it. But if you tap the soles of the feet, flick the soles of the feet forcefully and nothing happens, you know that this baby is not doing good and they're in an unconscious state, non-responsive. When we check a pulse on a baby, we can't really put our big sausage fingers on their carotid arteries because it takes up too much room. So where we check a pulse on an infant is the brachial artery. We find that bony protuberance, that bony part of the elbow, and just above that, right, we're going to feel for a pulse right there. You can feel it on yourself if you ever feel like trying it, or your significant other. Just find that bony part, the funny bone. It's called the olecranon process. Who cares? And you go just above it, and that's where you're going to find that brachial pulse on a child. Again, no longer than 10 seconds when you're assessing for respiratory or pulse or heart rate status, because we want to get to it quickly. The AED is not highly recommended for infants because, like I said, their problem is respiratory in origin, not cardiac. And then again, drive home the part that it's middle finger, mid nipple line, and then one finger above, depending on what your orientation is. If they're on the table or what hand you're using. If I'm using my left hand, middle finger, mid nipple line, my ring finger goes above it. If I use my right hand, middle finger, my index finger is above it, right? Middle finger, one mid nipple line, and then one finger width above it. And it's just different ways. It shows different ways to put that. So any questions on adult CPR with AED, child CPR, 1 and 2 rescuer, infant CPR, 1 and 2 rescuer? It's pretty much easy, right? Remember, we go at a rate for all three, child, infant, and adult. We do compressions at a rate of 100 to 120 beats per minute. For one rescuer, for all three, adult, child, and infant, we go 30 to 2 ventilations. For an adult, if there's 2 rescuers, it's 30 to 2, it stays the same. For children and infant, if there's 2 rescuers, you do 15 compressions to 2 ventilations. And if you're going to use AED pads on a child or an infant, make sure they're for children and infant, the attenuated pads, right? And know your different ways of doing compressions. You're folding your hands up, or you can grab your wrist and do compressions. Okay, so this is the video I was talking about earlier. And if you look where my icon is, this is a baby floating face down in the water. And who knows how much upriver he was without breathing. So we don't know how long this baby's been without air. And if you look here, there's a bystander jumping in the water, and he's going to save the baby. So if you see over here, mom's very distraught, and rightfully so. She should be, right? She's just seeing her child drown in a river. And he gets him out. And for all intent and purposes, that baby is a lifeless, limp baby. And to you and me, for all standards, that would be a dead baby. You don't see any movement, any breathing, nothing going on. So if you see there, he hangs the baby upside down. And then he takes off running, and in his mind, he probably thinks, well, the baby's lungs are full of water. Let me run with it, and maybe the shaking and the inverted disc will get the water out of the lungs. And that's what he's hoping, right? And he does that for a while. And this looks like it might be somewhere in Asia, and obviously it's not in America, because the majority of the layperson, or there's more layperson in the U.S. that are trained in CPR than in almost any other country in the world. All right, so finally now he starts CPR, but if you look, it's a completely wrong technique based on what I've told you already. He's using the two-handed approach on a child that size, which is wrong from the get-go. If you see how much of the area his hands cover, that's dangerous, right? Because he's over the xiphoid process, and he could puncture that and cause greater harm to the baby than he would by having your hands higher. So he's doing compressions, he's doing them wrong from the get-go, and not once has this baby received even a breath of air. everything's being done wrong. The compressions are being done wrong. No one's giving oxygen. They started from the get-go not doing it right, and they took a long time to finally do something that resembles CPR. So if you look here, the baby just gasped for air. So that now encouraged this guy doing compressions that he's going to really go for it, and he's not going to quit. And if you look at the hands now, his CPR is not the same as it was when he started because he's getting fatigued, right? But nevertheless, he's still continuing doing compressions. So if you look here, the baby just gasped for air. So that now encouraged this guy doing compressions that he's going to really go for it, and he's not going to quit. So now the baby comes back, he's crying, that baby is alive and screaming. And there's an adage in medicine that says a crying baby is a good baby. And this baby has a nice strong cry, which means his lungs are nice and healthy, and he's moving air through his vocal cords. So that baby is now alive just because of the efforts of one person, and that would not quit until he saw signs of life. And that's exactly what happened. So if I can have you guys pull away just one thing from this video, is just don't stop and do something, even if you think it's wrong. So great outcome on that, great video. All right, so moving on along to adult foreign airway body obstruction, or adult foreign body airway, adult foreign body airway obstruction, universal sign of choking. Universal sign of choking, the hands around the neck, obviously, like always, right? Choking, I'm choking, I'm choking. Mr. Jones, are you choking? Yeah, I'm choking, I'm choking. Is Mr. Jones choking? Mr. Jones is not choking because you have to pass air through the vocal cords to produce sound. He might have a partially obstructed airway, but he doesn't have a fully obstructed airway. What you encourage Mr. Johnson to do is, Mr. Johnson, you have a partially obstructed airway. He's going to look at you all weird, right? I need you to cough forcefully. And the old thing, patting on the back, rubbing on the back, come on, get it out. That does absolutely nothing for the patient, except maybe let them know that you're there, but it does nothing for them. The best thing they can do is to cough forcefully to try and expel that foreign object. Now, Mr. Johnson or Mr. Jones, now he's talking. Now he's not producing any sound. Now he's choking, right? What you do is you put your leg between his legs, stand behind him, and you grab Mr. Johnson around the waist, and at or around the level of where the belly button is, it doesn't have to be perfect. You grab your hand, bring your thumb in, make a fist, put it at that level, and with your other hand, you're going to compress or push in as hard as you can in an inward, upward direction. And you're going to keep doing that until one of two things happens. Number one, the object comes out. Two, Mr. Jones, Mr. Johnson becomes unconscious, and you'll feel him go totally flaccid. Once Mr. Johnson becomes unconscious, you're going to put him down on the ground and start compressions to ventilations at a rate of 30 to 2. You're like, what? CPR, but he was choking. Well, the idea behind that is, depending on where you are in the respiratory cycle, your lungs can actually go above your clavicles, above your collarbones. So look at all that potential space that we have to push on that chest and possibly get that object out, right? And without oxygen, there's no life. So if this person continues to not breathe, they're eventually going to go into cardiac arrest. I'm already doing compressions for them. And why do they tell you to give ventilations? Well, if I can get a little bit of air past the object, it's better than nothing. And if you guys have ever seen a drawing of the anatomy of the lungs, right? You get your main trachea that goes down and it breaks off into your left and right mainstem bronchus. Your left mainstem bronchus does a sharp left turn to where your right mainstem bronchus is kind of a straight shot. If I blow forcefully enough, that object can probably go down into the right mainstem bronchus. And now you have one entire lung you could inflate and oxygenate. There's a lot of people on this planet with just one lung, and they live nice, normal, healthy lives. And later on, if this patient survives, they'll do a bronchoscopy on this patient and get the object out. And let's be honest, that's not the biggest part of their worries. They're alive and breathing and thanking you, right? So that's the theory behind doing compressions and ventilations on a person. What happens when you choke? What is that? All right. So you always heard your mother when you were growing up, chew your food, chew your food, chew your food, don't just take a bite and swallow. And that is because when the objects are larger, it has a harder time going down the right pipe, if you will. The only thing that's protecting your trachea or your air hole is this flap of skin right here that's called the epiglottis. Anytime you eat food or swallow water, that epiglottis closes against the opening of your windpipe and doesn't allow anything down there except air, and then allows anything you've eaten or drinking to go down the esophagus, down into your stomach. Well, if you've swallowed something large, piece of steak, that's the number one thing that becomes an obstruction in adults. What becomes an obstruction in children and infants is hot dogs. That's probably because what the parents feed them the most. So you're eating a piece of steak, you don't chew it, and it becomes lodged between that epiglottis and your trachea, and it just stays there, right? That's why we do the abdominal thrust, to try and get that air to expel that object out. Don't be surprised, however, if you're squeezing that stomach and you hear the patient go, oh, and now they start breathing. What happened was this object came up into their oral cavity, the epiglottis closed, and then they swallowed that object down to your stomach. You're like, wait a minute, I didn't see anything come out. What happened? Well, they swallowed it. Don't be surprised if when they spit this out, they say something like, you're hurting me. Like it happened to me one time on I was actually off duty, and I saw this little old lady choking. She had a legitimate choking, no breath sounds being produced, and I was squeezing her. Big piece of steak comes out, first thing out of her mouth. She looks back at me and goes, you're hurting me. You're welcome, right? Have a nice day. So that's what happens when your airway gets obstructed. That epiglottis doesn't close. All right, moving right along. More pictures. You're going to wrap your arms around the patient's waist and make your one hand into a fist and make the other one flat and push against it in inward, upward motion until one or two things happens. The object comes out or Mr. Johnson becomes unconscious. If you have a pregnant female, we can't do that, right? We can't reach around the stomach because there's an unborn child back there. It will cause a lot of damage. So it's what we do is called the modified abdominal thrust, as we reach underneath. Let me get a full screen here. Is we get underneath the armpits as much as possible, and still in the same fashion, bring our thumb in, make a fist, and then push it with the other hand. We're going to push against the chest wall like we would when we're doing compressions to try and get that object to come out, right? We're going to do the same thing for an obese or severely overweight person. We're going to do that same technique. And let me keep going here. Now, if the patient is by themselves or they're so large you can't put your arms around them, one thing that chairs all have in common, except for bar stools, whatever, they all have a seat back, right? What you're going to do is encourage, or if they're obese and you're with them, you're going to encourage them to throw themselves on that chair back and try and get the object to dispel itself. You can also do this if you're by yourself. Over the years, I've had several nurses that said they were by themselves while they were eating a sandwich or whatever, and they started legitimately choking. No sound was being produced, no air was coming in, and they had to throw themselves against a chair back. That's pretty impressive, right? So just know that that's one of the things you can do if you have a patient that's so large that you can't wrap your arms around them. For child airway obstruction, there's really no changes except for the fact that you're not going to squeeze as hard, and you have the liberty of, once you grab them, right, you can now stand up with them instead of being hunched over and squeezing them. You could either kneel down to the child's size and squeeze the stomach nice and easy. We're not going to get crazy. Or we're going to stand up with the child and give the bear hug and do that same technique. Now, on infants, I can't do that because look how big that is, right? I'm going to do a lot of damage. I'm going to break their ribs. So on children, or infants, I should say, we're going to do back blows and chest thrusts. And how we secure the infant is with my index and thumb finger. I'm going to hold their chin very, very securely. And with these three fingers, I'm going to put it across their shoulder, their trapezius. and I'm going to go totally inverted with this child, right? I'm going to go totally upside down, and I'm going to use my forearm as a resting point, and I'm going to hold them nice and secure. And between the shoulder blades, right? The shoulder blades are the hardest, the scapulas are the hardest bone in the body to break. So don't worry about this. Plus, bones are very malleable at this age. You're not going to really do any major damage to these bones. What you do is 5 back blows, or 5. Again, between your thumb and index finger, you're going to hold that head. And with these 3 fingers here, you're going to put it on the shoulder. You're going to put the legs between your forearm, and how you do ventilations, you're going to do on the chest, right? Middle finger, mid nipple line, 1 finger above, 1, 2, 3, 4, 5. 5 back blows, 5 chest thrusts. You look in the baby's mouth. If you don't see an object, do not do a blind finger sweep. It's very dangerous, and I'll show you why in a second. So if I were not to secure this baby's head and I would do back blows, what's happening to that head? It's moving all around, right? It could be very, very dangerous to that baby. So that's why I hold the head. Now it's not going anywhere. 2, 3, 4, 5. Secure the head, shoulders. 1, 2, 3, 4, 5. Now I look and I see the object. I'm not going to use my big index sausage finger, right? I'm going to use my pinky finger to reach in there, grab the object, and let it out. If they're still not breathing, I'm going to breathe once every 3 seconds for them until they come back and start crying on their own. Again, check your brachial pulse to see if they have a pulse. If they don't have a pulse after you've cleared the object, continue doing compressions and ventilations at a rate of 30 to 2. And if somebody's helping you, you do compressions to ventilations at a rate of 15 to 2, right? Nice and simple, nice and simple. The biggest thing on that is let gravity do the work for you. You want to bring those babies completely upside down. And I think this might be it. Okay. Why I had mentioned earlier why we do not do a blind finger sweep on babies, and that is because they have not been their tracheas are not anatomically formed like it is on an adult. On an infant, if you see the picture on the right, it comes down to like a bottleneck, a concave, convex area, to where if I were to do a finger sweep and push that object down lower, it would get lodged right around there, and now it's not coming out. This is looking at it from the back. If they had a foreign body airway obstruction and I put it down under there, if I needed to do a cracothyrotomy, the area where I would do it is right around there in the front. But because now that object is obstructed, I can't stick a tube down there. So it's a very dangerous thing, right? On an adult, however, their tracheas are straight, nice and straight. And if I do a blind finger sweep on them, I could get it somewhere right up here. But if I go look at the front, if I need to do a cracothyrotomy, right, I could still stick a tube where it needs to be, and I could bypass that foreign object that's above there, and they could start breathing for them. So that's why we don't do a blind finger sweep on infants. We really don't want to do a blind finger sweep on adults, but we really don't want to do it on infants. And the rule of thumb for infants, letting them play with objects, is don't let them play with anything that can fit through a roll of toilet paper, right? The cardboard portion of toilet paper, if they could fit through that, don't let them play with it, because babies explore everything by putting it in their mouth. Don't let them play with that. Again, 5 back blows, 5 chest thrusts. If it's a larger baby, you could use your thigh to anchor them and hold them, so to make sure you don't drop them. That is the entirety of the CPR for healthcare providers: adult, child, and infant CPR with AED, adult, child, and infant foreign body airway obstruction. Nice and simple. All the different techniques. 1 rescuer CPR across the board is 30 to 2. And then for infants and children, 2 rescuer CPR is 15 to 2. That's the biggest thing I want you to take away. Don't do a blind finger sweep. 5 back blows, 5 chest thrusts for infants. And then doesn't really matter how you do compressions on an infant. You saw for yourself. As long as you do something, they're gonna be all right. Just don't give up. And then children, when you're doing compressions on children, you now have the liberty of using 1 or 2 hands to do CPR on them. That's about it, guys. Thank you for listening in, and hopefully I didn't bore you too much. But I enjoyed the company. Thanks a lot. We'll see you.